Right, hello and welcome everyone. You're at the National Voices Conference focusing on integrated care systems and how we can build better partnerships with people and communities through this agenda pursued vigorously by NHS England and the Department of Health and Social Care. Before we get going substantially, and also to allow people to still dribble into the room, very briefly, our tech slide. You need to stay muted during this hour and a half because we've got 500 people registered. You can't all be coughing and breathing and typing and talking to your dogs. So we need relative silence. We will try to unmute a couple of you who've submitted case studies and questions beforehand. We need to see how that pans out. This feels like quite a high wire act for the tiny National Voices team, so bear with us. You can turn your camera on and off. Feel free to do whatever feels more comfortable. There is a chat button at the bottom of your screen where you can introduce yourself and talk to participants. I won't be able to engage on the chat, and probably the speakers won't be either, unless they're even better at multitasking than I am. It's quite a lot going on and there will be quite a lot of chat volume. So again, if you find that all a bit too much, there's absolutely no expectation. You should engage on it, but do feel free. And we've got automated captions here. We know they're not perfect, but it's better than nothing. Right, on to the next slide. Right, the schedule for today is that we will do this opening session, have a short break where you can go and get yourself a cup of tea, stretch your legs, and then we run a number of workshops twice. There's one workshop we could only run once because the speaker not being available twice. And we know you've expressed your preferences, and Ella has done some unbelievable Excel wizardry to get you to increase the chances of everybody getting into the workshop they've chosen. But if it's not your first choice, that's just the way the arithmetics have landed. We were surprised by how many people were interested in this conference, and it is a much larger conference than we had originally anticipated. So there was no way the National Voices team could run all these workshops on our own. So we are working with colleagues and partners from inside NHS England and other organisations, and we're very grateful that they are running workshops for us. But for you as a participant, that might mean they might feel a bit different to each other. It might not be a uniform experience you taking part in these workshops. And we worked hard with the facilitators to make sure that they're interactive and that they work and that they're accessible. But please bear with us. If someone drops a ball on something, a lot of us are running workshops, have never met each other in real life or even online. So this feels a tad improvised, but we're doing our best. It's a free conference, just remember that. We then have a lunch break, we run the workshops again, and then we have a closing panel, which my colleague Sarah, our head of policy, will chair, and we have another set of really interesting speakers. And we'd love you to stay for the whole day, but we also appreciate you're busy people and you might not have time to do that. On to the next slide then. Right, agenda for now, we're in the welcome bit, and then we are gonna have a very short breakout, and then we have 2 keynote speeches, and then we have a panel discussion. With these, go to the panel. Yeah, so our panelists today, you know me, I'm the Chief Executive of National Voices. National Voices is a coalition of health and care charities. We're just short of 200 members. You will hear the announcement when we have recruited our 200th member, all the large ones, lots of the smaller ones. And we are focused on bringing lived experience into health policy debates and focusing especially on the experience of people who often aren't well served by existing service models. We're really privileged to have the set of speakers in the room who you will hear today. We will first hear from Matthew, who is the Chief Executive of the NHS Confederation, started about a year ago. Before that, he was the Chief Executive of the Royal Society of Arts, for Arts, something like that, the RSA. And before then, he was a Chief Policy Advisor to Tony Blair in Number 10. And he's made a splash since he started and talked a lot more than maybe we were used to hearing from the Confed about the need for better partnerships. So that's obviously really welcome, and we're really looking forward to hearing Matthew's thoughts. We will then hear from Professor Robin Miller. Robin is the Professor for Collaborative Learning at Birmingham University. He's very much an applied academic with an international reputation in relation to integration, leadership, and policy implementation within health and social care. He's one of those rare people who applies academic rigor to practical problems and stays very practical in his academic work. So always worth listening to people like that, I reckon. And then we have Dr. Rubina Ahmed, who is the Director for System Engagement at the Stroke Association. The Stroke Association are one of our very esteemed members, and she looks after a very broad remit, research, policy, public affairs, and campaigns, inequalities and prevention. And she also holds some executive and non-executive positions in the wider science and engagement space. Really happy to have you here today, Rubina. And finally, last but not by no means least, we've got Samantha Obago here, who's a lived experience partner at National Voices, and her background is actually in fashion and design, which is absolutely lovely that we have someone here who's not a health policy wonk and lives a different life, maybe from those of us who sit in these sorts of discussions a lot of the time. And she will let us hear about her own experience and maybe also about the role she now plays in National Voices and she's willing to play in the wider system. Right, and now over to you. You have very diligently filled in forms before you came here, and we have done some data crunching. And we are really chuffed that we have someone here from every single ICS area. You know, we have no marketing budget, and we managed to get the whole of England into the room, which is really lovely. And you can see here who are the top runners and riders. I was pleased to see mine there because I live in Southeast London. Hello, neighbours. Also, I'm quite chuffed that we've got quite a balanced group of participants. When we first opened our registration, all you lovely VCSE folk, all you charity colleagues piled in, and we were thinking, oh, isn't it typical that the charity colleagues are the ones, the voluntary sector colleagues are the ones who are really focused on the partnership question. But then all our NHS colleagues and our system colleagues caught up, and now we have quite a lot of people from the system side, from the statutory sector side in the room too, which is great. And hopefully you'll get to talk to each other in our workshops. You will see that 7% of people have said they're from an integrated care system. Welcome, a new set of organizations in the room. And you will also maybe notice that we did not put you into the NHS part of the pie, because I think that's the first thing we've got to hold on to during the day, is that the integrated care systems are not in effect NHS organizations. And I think we go wrong if we conceive them as such. Right, I'll leave you with that thought. And before we hand over to Matthew for his keynote speech, and can I just check with the National Voices team whether Matthew's actually turned up? Yes, hooray. That was a bit of a cliffhanger. Matthew, thank you, you're here. But before we hand over to Matthew, we do something else to raise the National Voices stress levels, because we know how to live. We're going to try to split you into 50 breakout rooms for 5 minutes, where you're going to be with a very small group of people, and we all just want you to say hello to each other. And what are you trying to learn today? Right, whilst we wait for people to come back in, let me set the scene very briefly. We asked in our pre-conference paperwork, we asked you to tell us if you're aware some examples of where you managed to integrate or coordinate support and care really well. We've had some very personal examples. Someone, Amy, I don't know whether you're in the room, described how you were benefiting from a single point of access system that was set up, that was run by a voluntary sector organization that helped needed to have with loads and loads of different services. You said in your submission to us, it was at one point 30 different contact points you were trying to manage. Now, managing that on top of ill health sounds pretty stressful. We heard some really small examples. Mark told us about delivering befriending training to a peer support training to a befriending group in his local church, and bringing that into the fold of mental health well-being services. Another smaller example we heard from was Hazel, who runs an organisation called the Nest Southwest, which in partnership with CCGs and PCN colleagues aims to support women through life changes, menstruation, menopause, pregnancy, birth, in a holistic way. And then we heard some more formal arrangements, like I've heard from someone called Andrew Martin, who was really proud of a collaboration between Change, Grow, Live, the Hepatitis Trust, and the Wiston Hospital in St Helens, who are eliminating Hep C in some so-called hard-to-reach communities, and are way ahead of target despite the COVID difficulties they've encountered. Robert told us about Healthwatch Suffolk running a really successful co-production ambassador program, where they train co-production ambassadors who work with the whole of the Suffolk system. And Kathleen described how at her trust in East London, they have set up a social enterprise who act as a conduit between the massive trust and the plethora of community groups it needs to engage with, and also simplified through that information flows and, importantly, procurement. And I was just so impressed with all these examples, and there were loads more, I can't mention them all here, because these things don't happen of their own accord. They happen because you have put your shoulder to the wheel, you've worked very hard, often against the grain of culture, of hierarchy, and not least corporate procurement, NHS procurement, which can be such an obstacle to getting to better working relationships between communities, their organisations, and the formal health and care system. So I just want to really salute you and say I'm really grateful for all this work you're doing, and really impressed. And we're going to use these examples, and we're going to invite you to write blogs about them and so on. And now that we know about all this good work, we won't shut up about it. Right. A better world is possible. I hope Matthew will find a way of bringing that to life for us. Matthew is the Chief Executive of the NHS Confederation, and we're really pleased to have him here, and he's going to speak to us for 10-15 minutes about what the ICS agenda might bring about in terms of different partnership between the formal health and care system and people and communities. Matthew, over to you.
Thank you, Charlotte. It's great to be here. You've now implied that I've got, when you booked me, it was 25 minutes, and then it was 15, and now you're starting to talk about 10 to 15. So I feel like it's the space I'm standing on is shrinking every moment. But I also want to fulfill the expectation that you placed on us that we would talk about personal experience, but I won't do that for long because I've only got 9 minutes left now. I would say my personal experience and the experience of people I've been very close to in the health system has been something which I hear a great deal, which is that there feels to be quite a lot of luck about it in terms of who it is you end up interacting with, and whether that's somebody who seems to be empathic, somebody who seems to be listening. I also think that I, as a middle-class person, have seen over and over again how middle-class people with the self-confidence and the contacts they've got are able to try to get better out of the system that the system might initially offer them, and that obviously is one of the sources of health inequality. And then in particular, I'd say that somebody very close to me has suffered now from long COVID for 2 years, and what I've witnessed there, I think, is classic problems around continuity and around the way in which, if you've got a wide variety of symptoms, as this close friend of mine has got, you get pushed from one person who's interested in one set of symptoms to another clinician who's interested in another set of symptoms. So you keep having to go right back to the beginning. And we've just changed GPs, and now we have a new GP who doesn't even seem to think long COVID exists. So I guess my experience is not unlike a lot of people's, which is it can be great, but it is a matter of luck. And it's clear that if you have got personal resources of a variety of kinds, you get better. So the importance, therefore, of the community and voluntary sector in helping people to engage, reducing the amount of luck that is involved in what you get, and supporting people. It's something I feel very strongly, and now I've come into the health system, I feel it even more strongly. So in my remaining 7 minutes, integrated care systems, as you'll know, this is the new way of doing things in the health service. It doesn't officially start for another week, exactly a week today. Although integrated care systems have existed for some time in many parts of the country. And that the fact that something is being introduced which already exists is just one layer of a very complex picture. So what I'm not going to try to do here is to summarize in any way what's going on out in ICS land, because A, they don't yet fully exist. B, they vary enormously from the ICS in the Northeast. I think it's 3.5 million people. There are ones in London which are several million people, through to very relatively small ICSs like Somerset or Devon, which are just one. They just span one local authority, one upper tier local authority. Also, ICSs are internally very complex. They comprise systems, which is the geography I've just described, but also within those systems, places which are often coterminous to local authorities. I'm sorry, I have a dog that assumes that every stranger wants to be its best friend, but everyone who puts anything through a letterbox is trying to murder us. So excuse the yapping. So they contain places. So if a system is bigger than one local authority, it will be encouraged to devolve work to places which are the size of local authorities, and in many areas also to localities. And indeed, when we think about the future of primary care, I think you're going to be hearing a lot more about the development of locality-based working, particularly around clusters of primary care networks. And then the other kind of element of all of this is collaboratives, which is that hospital trusts are being encouraged to work together in either horizontal collaboratives, so for example, bringing several hospitals together in a collaborative, or vertical collaboratives, so for example, bringing a hospital, mental health trust, a community trust, maybe primary care as well, into a collaborative. And even I think in Northwest London, I think I'm right, there's a voluntary there's a VSO collaborative. We're bringing together the voluntary sector so that it engages. And I think, by the way, that model of a VSO collaborative as a kind of concrete element of the kind of leadership of ICSs is a really, really interesting one. Now, the relationship of all of that structure to the voluntary community sector is itself complex and itself varies. ICSs have basically two boards. They have integrated care partnerships in which the health service is only part of it. Those partnerships also have local authorities on them, and they will tend to have representatives of voluntary community sector on them as well. And integrated care boards, which are more focused on the health service itself, but they too may have people who are members of representing the voluntary community sector, either to do that role, or because they've got non-executive directors who have lived experience, direct involvement, or even leadership role in the voluntary community sector. So it is a very complex picture. And one of the things that we have been talking with Charlotte and National Voices about, and I think we need to take forward, is as we see different models of engagement of the sector at system level, at place level, at locality level develop, we need to kind of to map that out and start to identify the principles that should underpin effective engagement. What are the success factors for ICSs? Well, again, it's very early to say, but I would say that it looks like, from the outset, two things are really important, two sets of things. Firstly, what is always important: leadership, relationships, clarity of purpose. But I think there's a second thing that's also really important, which is how ICSs view themselves, they view their role. And I think what's critical there is that ICSs do not see themselves as a layer. So if you're not inside the health service and you look at the creation of these new bodies, it is completely understandable that you'll think, well, this is just a new health authority, like strategic health authorities, or if you go back long enough, regional health authorities, or area health authorities, or CCGs. I think the best way of thinking about ICSs is not as a layer, but as an enabler. And what I'm seeing in the places where I have the most hope for the role ICSs will play, it's where ICSs, and not just ICSs, but providers within systems, see the role of the ICS as enabling all the parts of the system to work more effectively together. And indeed, many years ago, before when I was at the RSA, I wrote a couple of blogs saying one of the problems of the public sector and with place working is that we invest in cement, but we invest in bricks, but we don't invest in cement. We invest in cogs and pistons, but we don't invest in oil. And so I think where I'm seeing what looks like a really interesting possibility for the ICS is that it sees itself as fundamentally being about enabling the bits of the system to work effectively together. And similarly, at place level and places, the place structures are like mini versions of those ICPs. So places will also be a combination of health service, local government, voluntary and community sector, as will locality bodies. So that's going to be critical, I think. If ICSs turn into a bureaucratic layer, then I think the chances of success are limited. But if they see themselves as an enabler, which means a very different type of leadership, by the way, and critical to that, whether or not ICSs do develop in that way, is going to be the role of provider. And so in some places, I see providers feeling that they're losing autonomy from the old system that was based upon really focusing on single organizations and a more competitive framework. And I see providers worried about the loss of autonomy, worried about what ICSs will bring, worried that it will be another layer of control, adding to the center and to the regions. But where I see things looking positive, it's because providers themselves have got stuck in and they have said, what do we need to do to help ICSs be the body we need them to be? And where that kind of quality of conversation is going on, then I think, it looks really quite exciting. So, and then the final thing that I think is really important as a success factor is this relationship between these two bodies, the Integrated Care Partnership, which is truly a collaborative body where the health service is just one voice amongst others, and the Integrated Care Board, which looks much more like a more traditional health body. And the voluntary community sector will be more strongly represented, generally speaking, at that ICP level, that collaborative body. And I think one of the things that's really important to the success of ICSs is that we see ICPs playing a supportive challenge function. So the role of the Integrated Care Partnership is to have a set of strategic objectives and then to hold the ICS, not just the ICB, but local government, voluntary and community sector to account for delivering that shift. So at the heart of that argument is that there are a set of things we've been trying to do in the health service or that need to happen in the health service and that we found very difficult to do. And many of those things were in the long-term plan that was published in 2019, but then COVID got in the way. Now we're waiting for a new long-term plan. But what we know is that the shifts I'm about to describe, and I'm just going to literally do them one line each because I've nearly run out of time. These shifts are very hard to accomplish because the health service tends to revert to the ways in which it tends to work, the more kind of paternalistic, technocratic kind of way, medical model kind of way of working. And so if we're going to shift, we need grit in the oyster. And so I think we should see ICSs as having this dynamic kind of tension between ICPs who have a very different vision of how the health service, health and care system can work, challenging the ICBs, which is where all the money is and where the traditional leadership is, to go on this journey. And so what are those shifts? And this is where I'll end. Firstly, the shift from a focus on demand to a focus on need, which really is at the heart of the problem of health inequalities, which is that the moment the health service meets demand, expressed demand, it doesn't meet underlying need. And of course, COVID taught us a lot, and the vaccination program taught us a lot about what we have to do if we actually want to reach out to everybody, and rather than just reaching out to those people who come forward. So how do we move from meeting demand to meeting need? Secondly, how do we have a system that incentivizes outcomes, not activities? At the moment, the health service incentivizes activity. That is not the same as outcomes. So how do we move to really focusing on health outcomes rather than activity? And of course, that is particularly difficult right now because we are obsessed with dealing with the elective waiting list. And that's a classic example of where we're responding to demand and responding and measuring ourselves by activity. Thirdly, how do we move resources upstream out of acute into community, primary, prevention? We've been banging on about that for years. How do we do that? Fourthly, and this is really important to me, really important to the Confederation. I've been talking about this a lot. I talked about it in my speech to our big conference last week. How do we have a different relationship with communities and patients? And this is more, and this is on every level, from the kind of strategic allocation of resources and configuration of services, right through to how we redesign services. I think there's a whole cluster of changes in the way in which we think about care, which have enormous potential, but we're just not having the conversation we need to have at any level, national, system, place, and indeed kind of clinician to patient. Virtual wards, patient-initiated follow-up, anticipatory care. All of these things have got enormous potential, partly to help shift resources upstream, but they all require a shift in the relationship. They all require a shift in the kind of trust, engagement, reciprocity nexus between the system, and clinicians on the one hand, the patients and public on the other. And we've really got to really shift that. And working with local government, we can learn a lot from the best practice of local government. As I said in my speech last week, the health service tends to view engagement as a date. If it works well, we'll do it again. If it doesn't, we're going to walk away. Whereas local government tends to view engagement as a marriage, something you stick with even when it's tough because you have to. Two final things: we need to shift to health in every policy. So understanding that what the NHS does is only a determinant to 20% of health. So thinking about working with local government and other bodies to make sure that we really think about health in every policy. What is probably the biggest challenge for health in the whole country right now? It's the cost of living crisis and debt, and the way in which that will drive problems, particularly in relation to mental health. And then finally, how do we bend the demand curve? How do we envisage getting to a position where we don't have to spend more and more on health? Because it's clear we're facing now quite high levels of public resistance in relation to that. And all of those changes need to be underpinned by technological possibility, because technology, data, digital, biotech, biomedical tech is going to be changing the context in which all these things happen. Last line, I think there's enormous possibility here. But last week in my speech at Confed Expo, which you can watch on YouTube, do please watch it on YouTube. I'm having a battle with my son, who's a hip hop star, because he's got a new song on YouTube and he's getting more views. Why would anybody rather watch a really entertaining 4-minute hip hop song when they can be watching a 23-minute speech? I don't know. But anyway, do watch it on YouTube. But in that speech, I talk about building a bridge to the future. I say the big challenge for us is that we are at the moment facing this enormous capacity squeeze in the health service due to overwhelming demand, shortage of workers, shortage of capital, shortage of revenue. All that extra money we were given because of the cost of inflation, we are now having a real terms cut in the health service this year. But we've got to think about that better future and where we can get to. So we've got to, at the same time, tackle the problems we've got now, the real problems and issues that matter to the body, but have that different vision of where we can get to. For the Confederation, making this work is about challenging the centre to lead in a different way, challenging government to be realistic and to give us the commitment we want, and challenging and supporting ICS and place leaders themselves to lead and work in a very different way. And doing that, it's brilliant working with National Voices, because I think on issue after issue, actually, we stand with you in calling for a different kind of leadership and a different kind of engagement at every level of the health system. I've gone on 3 minutes too long. I'm very sorry, Charlotte.
You've done brilliantly well. Thank you, Matthew. Really, really nice and clear. Those 6 shifts, I think we will pick up again in our conversation. I think particularly the bending the demand curve is the final one you mentioned, where our sector has a massive contribution to make. I've just been watching a bit in the chat and people talking about carers, for example. I think just a mindset shift where we understand how much need carers actually hold and what a great investment it would be to support carers in their work much better, much more effectively.
I apologise for not talking enough about carers.
No, that's all right. Sorry. Just mentioning it as an example.
No, it's a really fair point, and
it's just one of those things. It's just one of those things where I think we're missing a trick.
Yeah, no, I completely get it.
Okay, I could respond to that very happily with another 15 minutes speech myself, but I won't. I'll hand over to Robin, who will talk about work he's done over here and his team have done over the last 10 years, looking at what the NHS does when it tries to integrate with itself and others. And I find it really instructive to learn from that recent experience. How is it going to be different this time? Robin, over to you.
Okay, thank you, Charlotte, and thank you, Matthew. So my name is Robin Miller, a Professor of Collaborative Learning, University of Birmingham. And one of the main focuses of my work is integrated care. How can we help health and social care to work together, but also the statutory sector and the voluntary sector? And the reason why I think that's such an important topic for us to focus on is before becoming an academic, I spent about 15 years as a social worker, as a team manager, and as a senior leader in health and social care services in the West Midlands. And a lot of the groups that I was supporting were people with mental health difficulties and people with learning disabilities. And what you quickly realize is that for people with more complex needs to have a good quality of life and for their family to feel supported, it requires good collaboration, not just between health and social care professionals, but also with housing, with leisure, with employment, with care support services. And so when I became an academic, I really wanted to understand how we could do that better and how we could use evidence and theory to inform what was happening on the ground. And that's become very real to me over the last 6 months. My mum, who's 79, is suffering from advanced bowel cancer, which is obviously a very difficult time for me and my family. And what's been really noticeable is the individual care that she's received from the health professionals, the doctors, the nurses, the occupational therapists, the radiologists, has been really fantastic, really excellent set of professionals who know their job and who treat mum with respect. What's been really poor, though, is the coordination and the communication. And one of the things that's really struck us that she's under a cancer multidisciplinary team. And we just hear rumours of, oh, your mum's case is going to be talked about next Friday, or, oh, it wasn't talked about this Friday, it'll be talked about the Friday after, or a decision has been made, somebody will phone you next week, an unspecified date. And whilst it doesn't actually cure mum's cancer, what it does is it adds a lot of uncertainty into what the situation is going to be, and a lot of anxiety for her and the rest of her family in relation to what the next steps are. And just by a little simple communication point after each MDT would make a huge difference to her and to us as a set of individuals and as a group. So that, to me, highlights really why person-centered and coordinated care is so important. And so what I'm going to do in my 15 minutes that Charlotte has allocated me is I'm going to reflect on an evaluation that we've been undertaking for the last 7 years, would you believe, with the London School of Hygiene and Tropical Medicine, looking at the Integrated Care and Support Pioneer Programme. Next slide, please. And this program was a pilot program, which was started in 2013. Next slide, please. And when you look at integrated care internationally, one of the very common ways that we use to try and understand what will work in a local context is to set up a program of pilots. And we use many words for that. In England alone, I can think of words such as we've used vanguards, new models, champions, trailblazers, and currently we've got front runners as the latest term of pilot programs that we're deploying in integrated care. And the reason for that is that if we know we've got a set of challenges, we've got some people who are keen and seem to be making progress, it makes complete common sense to ask them to try and take things forward at a greater speed and a greater pace than others have been able to achieve, and then draw out the lessons from that. What doesn't often work so well with pilots is we don't actually take time to learn from the pilots before we plow on to the next policy initiative. But let's leave that for just now. What's unusual about this evaluation is generally as researchers, when we're asked to look into pilot programs, we're given a very tight window to do that. So often it's the first 3 years we're asked to evaluate what progress they've made, understand the contributing factors, and then to comment on whether or not this is an effective way to deploy our meagre health and social care resources. And as researchers, that's deeply frustrating because basically by the end of 3 years, often programs have only just got going, impacts take much longer to achieve, and therefore we can't actually provide that definitive view that people are after. What's unusual with this evaluation is that it's been going for 7 years, so it provides longitudinal insights into integrated care across England. And also it's contemporary because we've only just finished data gathering from our local areas and our multidisciplinary team sites. So it's relevant, but also it's a long scale evaluation. And indeed, in many ways, the evaluation has lasted a lot longer than the Pioneer programme itself, which actually finished in 2018. And this was introduced by the coalition government as a way of trying to understand how health and social care could integrate together. And there was no money or very little money per se. It wasn't like the New Models of Care programme. But what you did get was you got a national recognition, you got access to a national learning programme, you got interest from national government, and you also got to work with a group of applied health and social care academics. Next slide, please. So what were the, next slide, please. What were the integrated care and support Pioneer supposed to do? Well, the first thing was it was very much focused on integration between health and social care. So when you look at the history of integrated care, it actually began thinking about how hospitals and community health services, general practitioners could work together, which is obviously still very important and not always done as well as it could be. But the Pioneer programme was about how health and social care can work together. So therefore, local authorities were very much central to becoming a Pioneer programme, as was the Local Government Association. So they were to drive change at scale and pace, recognising the fact that, yes, it's great to have some innovative small-scale projects, but we need to do this for the whole of our populations, and we need to do it quickly because actually people are experiencing poor care, health inequalities are on the rise, and also we need to be able to use our money more effectively. Perhaps one of the unique features of this pilot programme in comparison to the others is it was also not to just involve health and social care statutory services, but also the voluntary sector as well. And when you look at the programmes that were involved with that, there's some really excellent examples of voluntary sector contribution. For example, there was a Living Well programme in Cornwall, which is still running, which was developed in partnership with Age UK, which is looking at how volunteers can support people who are isolated and lonely to connect up with their community resources and therefore improve their networks, but also improve their well-being. So voluntary sector was a central part to many of the integrated care and support pioneers. Some of them were quite small, focused in a particular locality. Some of them were a whole system transformation program. And crucially, when they applied to be part of this Pioneer program, they had to evidence how they were going to meet the I statements that were developed by National Voices all the way back a decade ago. And I think just as a small aside here, I think it's quite difficult to underestimate the influence of the I statements that National Voices and partners developed. A very simple but yet profound way of demonstrating what does good integrated care look like. In some ways, it's a shocking fact that before those was developed, we had no common understanding of what good integrated care would look like from the view of people and their families. And the I statements are being used across the world. And I do a lot of work through my International Journal of Integrated Care, and time again, people will use the I statements as the benchmark for what's important in integration. And yes, we haven't achieved them as yet, but we do understand what good would look like. Okay, so next slide, please. So what do we do in terms of our evaluation? Well, those multiple work programs, which I won't go into. The two things we're going to talk about today are our really rich ethnographic study of multidisciplinary teams, and I'm trying to understand how teams work in practice and what difference it makes to individuals and their families. And the second thing we did was a panel survey, and that basically means we did a repeated surveys to local leaders of the Pioneer programme. So that includes people in local authority, clinical commissioning groups, acute hospitals, but also the voluntary community sector, about what was working and what was challenging in relation to their integrated care aspirations. And again, that's quite unique because often you get a survey that's done maybe over a couple of years, but to have it over 7 years provides some longitudinal insights about what life was like for them and what supported and what made it difficult for them to achieve those I statements. So next slide, please. And indeed, the next slide too. Great. So what were some of the facilitators of integrated care in these areas? And interestingly, it really does echo the comments by Matthew in his opening address. So one of the things that really comes across in integrated care is that if you've had a tradition in a local context of working together better, of establishing good relationships, of developing trust, then it's much easier to bring in new integrated care innovations. Now, one of the issues with that is that it's good that those areas can progress and take things forward, because there's more to do. But actually, one of our major issues is, what do we do in areas which don't have that tradition, who don't have that culture of collaboration? How do we encourage, stroke mandate, the people who lead those health and social care organisations to do something differently? And that's a big question, I think, for the integrated care systems. A second thing which came across as a strong facilitator, and again, Matthew touched upon this, was that there's many different ways of understanding integrated care, of trying to predict what we think the impact will be. Is it to do with patient and individual experience? Is it to do with addressing health inequalities? Is it to do with workforce well-being? Is it to do with using money more effectively? And all those things are legitimate outcomes to expect of integrated care. What we need in a local context is to understand what the priorities are and what the aspirations will be for 3 to 5 years for integration in that locality. And we often don't do that. We often have very big, broad, grand aspirations, which are fine in principle, but actually, how do we understand progress? Okay, next slide, please. So some of the other barriers, some of the barriers that we found was clearly a lack of that clarity and a lack of that relationship. But also, I think what the integrated care pioneers found, which again, I think is important to highlight, is that the divides between health and social care, the way that we have trained our professionals in a very silo basis, the way that our organizations traditionally have a very set of unique priorities and incentives and punishments for behaving in a certain way, and a lot of the national policy not being sufficiently joined up means the divides between health and social care are really quite stark. And to go back to Matthew's building metaphor, if we think about integrated care and the divisions between organization and system as being major cracks within the earth, what we do with integrated care sometimes is we build shanty towns on top of them, which hold in place until there's a major tension between the organizations. Then the gap opens, the shanty town collapses, and we go back to how we've worked before. And I think one of the major things that integrated care pioneers show is that this is a long-term endeavor which requires consistent action and motivation to do that. And we're not going to solve these things in 3 years, 5 years, or 7 years. We have to do it in the long term. One of the things I think is quite striking by the panel survey is actually the lack of highlighting of engagement with the community and voluntary sector. So it doesn't, if you look at the top facilitating the top barriers, a good engagement or a poor engagement is not mentioned in either of those. And I think that's interesting, actually, because remember, these integrated care and support pioneers were to take a whole system approach. And one could say that perhaps one of the issues with integrated care is we start off with great aspirations of involving communities, individuals' lived experience. When times get tough, and we have to kind of focus down and try and bed down and trying to move things on, sometimes that's the element that gets lost. And that is a complete crying shame, because actually that's the contribution and that's the kind of radar that will enable us to make sure that we stay on track and we focus on what's important. So next slide, please. So we did a reflection as part of a 10-year anniversary edition of the Journal of Integrated Care on what have we learned from integrated care in England. And there's a set of about another 15 papers from around the world reflecting on integration from their different contexts. So it's definitely worth a look at. And what I would say is that the experience of integrated care pioneers is very, very typical. So that notion of the traditional relationships, long-term endeavor, all the challenges that they faced in terms of workforce, in terms of times of austerity, etc., were there across the board. So whilst we have made progress with integrated care, and I think it's fair to say we have moved on from where we were 10 years ago, we've still got such a huge way to go before it becomes a reality. We see that emergency admissions continue to grow during that period. If you look at surveys of people who access primary care, they say they're less involved in their care, and health inequalities are worsening. And as Matthew said, the cost of living crisis is the greatest health and social care pressure that we'll face in current times. So integrated care systems, I think, are a unique opportunity. And one's always got to be positive to think about new developments and new initiatives. They have many factors which actually are positive. So they have got greater autonomy than areas had before in terms of how they achieve integrated care. They have got a governance structure that does involve the voluntary community sector, and does involve people with lived experience. So we've got to be hopeful that they can bring together, they can be the facilitators, as Matthew highlighted, that will enable us to at least achieve more of these I statements that we set in 2010. So going forward, if you want more information about the Integrated Care and Support Pioneers, next slide, please. There's a whole set of resources online which you can access through the slides. And I say I'm very interested in integrated care. I'd love to hear from you during the day, but also after the event as well. And I shall now hand back to Charlotte, because I think I'm 15 minutes on the dot.
Yes, you've landed the plane in time. Thank you, Robin. Robin and his team are also running one of our workshops later, talking about what they've learned about actual multidisciplinary team working, which I think will be really interesting, because it's one of the learning points from the wider program, that it's much more about what the team is able to do than what the structures look like. Can the team share information? Does money flow through the team in ways that align with the outcomes you want? And I think that's something that we as health policy roles often don't think about enough. How is this actually going to be delivered by teams? So if you're signed up for that workshop, I encourage you to go along and talk to Robin and some of his colleagues about what they've learned. And we've also got a partner from Positively UK who will talk about their experience with embedding the VCSE in a multidisciplinary team looking after people with HIV. Right, and that just reminds me to tell you that if you have loads of questions and ideas and thoughts, please don't think you have a chance, just talk about them. That's why we've programmed 2 workshops for you to all attend, where you can, you know, splurge this and engage with each other and learn from each other. Now I'm interested in what Sam is making all of this. Sam is one of our lived experience partners. We have offered her training to be a coach, a lived experience coach, who will support system leaders thinking through the challenge of person-centered care. And Sam's been listening with intent to what we've been speaking about today and so far. Sam, over to you.
Hello everyone, my name's Samantha Ofebu. I'm a Black woman wearing glasses with curly hair, for everyone to know out there. It's been amazing listening to this. I must say my background, as Charlotte said, is in fashion and design and retail. So talking about healthcare and social care is very new to me, but being involved with National Voices, I'm learning on the job about so much. And there was so much that Matthew and Robin have said that's like resonated with my personal experience. I was a new mum last year in my 40s, had my maternity care in London, then came back to Liverpool, where I'm from and reside now. I have a son who was diagnosed with a congenital heart issue and Down syndrome at birth. So there's been lots of these different things and sectors, intersections that I've had to deal with within maternity time. And after my son was born, his heart defect was discovered when I was pregnant. So that was kind of like a baptism of fire. You have the euphoria of, you know, being pregnant, having a baby, and then getting told, you know, there's a really serious heart condition, and you kind of feel like you're left in the lurch in that. And that's why, you know, on this topic today of integrated care, I don't feel, like Robin said in relation to his mother, there's been amazing professionals who've helped me and my son, but the cohesion of it has been terrible a lot of times. I really want to salute NHS professionals. I think they do an amazing job, but the coordination between different departments is what has been a letdown. It's what caused anxiety and stress, and not knowing where to find help. So in the beginning, being in maternity time, it would be like, okay, your son's got a congenital heart issue. We'll usher you to a little room and tell you about genetic counselling, and then here's a few leaflets, and you're just kind of left in the lurch. And because I'm a creative person, I'm not very savvy when it comes to social media and you know, computers, even if people might think so. So being told to just go and find the link and look for this and that, if it wasn't for the voluntary sector, I don't think I would have had help that I've had, because it was charities like Positive About Down Syndrome, PADS they're called, or Tiny Tickers, who deal with babies with congenital heart issues, that brought me together with peer groups so I could speak to people in my community who were dealing with the same issues. There was nothing, the cohesion there was found by me having to go and find things, having to look online. It's made me a lot more literate when it comes to being online and social media, but it's been really tough. And I'm hoping that, from what Robin said before about coordination between departments, that can be something that will be a major change going forward, because it has been a lot. And moving forward after having the baby, having to deal with different things. Examples are, you know, my son has got this congenital heart issue. The cardiology department at Alderhay are amazing. But because he also has Down syndrome, there's lots of different checks that he has to have in his first year of life. And I've even been told at appointments, you know, I'll make sure you ring up and just double check with this department that this has been done, because sometimes we don't really communicate the way we should. And it's great that it's highlighted, but it's just more stress for me. I'm already a new mum, you know, I'm already having to deal with becoming a parent carer that, you know, is a whole new thing for me. So there's a lot of things I have to do to coordinate my son's care, which is great and okay, because I am his parent. But I think there could be a lot more help if the system was in place to support that. There's a lot more that I feel like I have to do personally, and as much as I want to take responsibility with that, I would like to have more support. So yeah, feeling isolated has been a major part of this, because when people don't communicate, or when departments don't communicate, or just kind of fob you off, to be honest, you don't really want to go and find help elsewhere. So I'll reiterate, going back to the voluntary sector, if it wasn't for the help I've had from them, I will feel incredibly isolated. And the work that I've been doing with National Voices has been amazing. I did training earlier on in the year for coaching and mentoring, and what that's brought to the fore is about asking the right questions. So if, as a lived experience partner, I'm able to be around the table or be in front of system leaders to be able to ask them the questions during coaching sessions to make changes, to make these positive changes, then that's where the interaction between someone like me who's from the community and with this lived experience gets to work alongside system leaders to make change. You know, I used to have a shop in Brixton in London, and when I think of the community I was from there, I saw how, you know, I used to sell art and a lot of it was very expensive. So, you know, we had to listen to our customers who were like, we really love this, but it's unaffordable. So we had to find a way to make art accessible, but make it affordable. And that only came from listening to the people who come to my shop, who are my community. So now when I think of, you know, when I came on board with National Voices, and they were, you know, people that I work with, like Kem Worthen, who's on in the conference today, were like, you know, you've got skills already to do this. And I was thinking, well, I don't know anything about health and social care, but what you need to realise is people's lived experience, be that from jobs they do, be that from being parents, carers, having particular illnesses or ailments, mean that they've got so much information and so much to offer, and our seat at that table when it comes to decision making or helping make decisions is just as important. And I think it's the best way forward to kind of implement positive change.
Thank you so much, Sam. What a rallying cry. And I'm only disappointed that you didn't bring little Theo along, because last time he spoke to us, he was on screen as well, which was absolutely delightful. I think what I'm taking from that is something that Robin also mentioned, which is that at moments of, you know, heightened emotional strain that we sometimes experience when we're in contact with the health system, we're often asked by the health system to sort of double up as secretaries and as kind of administrators. And I think, also thinking about my own experience of looking after my husband with terminal cancer, it's very unfair to ask people at that point in their lives to sort of focus their energies on admin and PAing rather than where they need to focus their energies, which is healing and making sense of a new reality. Right, I think Rubina, who's our final contributor today, also knows about the shock that sometimes is the starting point of a health interaction, because stroke is one of those illnesses that just happened with a massive acute intervention, and then people have to rebuild. their lives, and they rely on brilliant coordination. And I'm wondering what you're going to say to us, Rubina.
Yeah, so I suppose the first thing I just want to say is you also asked about a kind of a personal reflection of the use of the health system. And really, I've used the healthcare system, but actually the example I want to give is navigating the NHS and the social care system with my dad, who had COPD for 10 years before he passed away at the age of 67. So very, very young, 2 years ago. And, you know, so first of all, it was the questions of why. So my dad never smoked in his life, was very kind of anti-tobacco. And but he had asthma, and there were other inequalities in his life that led to him being diagnosed with COPD so early on. And although my dad arrived in this country at the age of 14, he was pretty much illiterate, and his level of English was enough to get by, but was not enough to navigate quite a complex healthcare system. And so actually it was me and my siblings that helped him navigate that system. And I can tell you, it felt like a fight. And I think that was the overarching thing. So he had not just COPD, he also had diabetes, and then suddenly he'd have a little bit of angina. And it's how all of those things interact, but also the NHS is very much siloed. And what we found towards the end part of his life was really the social care aspect that he needed. But for 4 years, we had so many appointments around the adaptations that he might need at home, and actually he never got any of those before. And the appointment for him to get a chairlift was made after he passed away. So it's all a bit too late. And I think that was the thing for me. It's really complex. He was very lucky because he had a very good GP, a GP he sought out, because that GP spoke his language, and he had him on speed dial, and somebody who could help him navigate the system. But I think that's also the experience that is for many of my generation, and for those of us who have parents who emigrated to the UK from Southeast Asian communities. We're finding ourselves in that situation now, where we have older parents who have been in this country for a long time but are now aging in this country. And so it's a bit of a it's quite intensive, I would say, for many of my peers. And I think reflecting back on at my role at the Stroke Association, I think this is one of the reasons why health inequalities is something that I'm so passionate about. And with stroke, so a stroke can happen to anyone at any time, and really stroke is very integrated, because suddenly you have a stroke. Often there's nothing that indicates that you're going to have a stroke, and then you just have a stroke. And it's how quickly an ambulance responds to you, which we know now is something that's a bit of a challenge, and how quickly you get into hospital, how quickly you get therapy and treated in hospital. And all of that's a bit of a postcode lottery. So if you're in London, you're probably likely to get access to a hyperacute stroke unit and get, really game-changing interventions and get help, get the care really quickly. Whereas if you're in the east of England, where they don't have some of these hyperacute services or a mechanism to get people in, you're unlikely to get some of these, interventions. And actually what that does is then reduces your chance of, having a good outcome from your stroke and recovering. So all of it is linked, and people having a stroke will then have differing levels of disability and differing levels of need. So somebody who has a stroke might go on to recover really, really well and have no long-lasting impact, whereas another person might have quite severe disabilities. They might have aphasia, where they can't, where they have difficulty communicating, and because it happens in the brain, so which part of your brain it happens in can really impact your outcomes from it. And the work that we do at the Stroke Association is we're very fortunate. So we are commissioned by NHS England in many parts of England to deliver what we call kind of stroke recovery services. We have stroke key workers who often start at the point of people being in hospital and help them navigate through discharge. They do self-assessments, they think about the holistic needs of that patient and what they might need to help them really recover. And I'll say one of the challenges for us is, and somebody said this yesterday to me, in the NHS, if you can't measure it, it doesn't get done. And for us in the voluntary services, where often the types of things that we're doing are seen as the softer added on bits, it's hard to demonstrate the impact of what we're doing, particularly in that interface between the NHS and the community setting. And so that's something as an organisation we're trying to focus on, because also metrics don't necessarily have to be numbers, and it's about patient experiences. So I'm hoping actually with the integrated care systems, and Matthew's talked about a bigger focus on outcomes, but I'd like to see us talking about patient experience as well, and inequality in patient experience as well. And I think we want to see the voluntary sector being not just seen as a nice add-on, but actually an integral part of that system. We should be there at the decision-making table, helping to set those strategies and deciding how the funding should be used. When we're talking about the workforce challenges in the NHS, which many of us are very aware of, well, we're actually part of that solution. We can help relieve the NHS of some of that burden by taking on some of the work. The work that we do with carers, is often not recognised, the peer-to-peer support we do. So I think, stroke is a good example of how the system can work, from our prevention work in terms of awareness raising and communications, through to the work that we do in kind of campaigning around better access and equality of access to good NHS services, through to the work that we do with stroke survivors themselves and their families to help them really rebuild their lives after they've had a stroke. So my hope is that with the integrated care systems, we are definitely an integrated part of that and not just an add-on.
Thank you so much, Robina. And I do think, as the services the Stroke Association provides as the motor that Matthew was talking about to start with, you are the integrator of stroke care, I think, often talking much more holistically about what people might need when they lose their language, or when their relationships are strained, or the financial impacts and so on. It's really impressive. Thank you. We are a bit behind schedule, and I therefore have to skip a stage I was really keen on the agenda, and I apologise now to Rashmi and Ailsa, who I've lined up to talk about a case study of integration they are leading on in their patches, but we will talk about it at a later stage, and we will make sure we make noise about this brilliant work you're doing. Many of you have provided us with questions, and again, we won't have time to go through all or even a large proportion of them. I'm going to pick 4, hopefully, with the remaining time, and ask them of our 4 panelists, and I'll ask for relatively brief answers so that we get through them before we wrap up. First of all, maybe let me start with Matthew. It's a question that Chloe asked and Margaret about the timelines that are now expected of the ICSs, particularly as they're meant to develop these area plans. And we think these area plans are really crucial because they describe the need and the ambition for better outcomes. Really crucial process. Now, that needs to obviously be co-produced with communities. What is the need around here? Because it won't all be stuck in NHS data sets. I'm just thinking, for example, of the needs of younger people with mental health. That's not reflected in NHS data sets. So how are we going to get those experiences and those voices around the table? And given the timelines are so tight, I think ICSs are expected to have those plans ready in March 2023. How can we avoid this becoming totally tokenistic? And I'm hoping that you might say, oh, we mustn't let it become tokenistic, but actually have an idea as to how ICSs could approach this process so that it is genuine. Matthew, what are your thoughts on this?
Well, my answer is simple, Charlotte, which is help. In the sense that we are the organisation that represents ICSs, and all 42 have joined, which is great. But we've been really clear that we want to work with them in a way that is challenging as well as being supportive. So our job is not just to advocate for ICSs, but it is to press them to be as good as they can be. And part of that is bringing in people like yourself, Charlotte, who can also challenge ICSs to do things in the right way and to develop case studies of ICSs in places that are, which not so that we can lift and shift them, but in order to kind of inspire places to do things differently. So you're quite right that NHSE in various ways is setting all sorts of quite unrealistic timescales, and there is a danger of box ticking. But we want to try and make that different. And just as a kind of token of that, we have engaged as a partner in leadership development for ICS, is a body that has never worked with a health service before, but has worked with, I don't know, British Army, Tesco, Save the Children. You know, it's worked with a variety of organizations and has got an incredibly impressive but really challenging approach to process and relationship building. So, you know, Chris Ham said some months ago, and this is probably the single quote I most often repeat, that if ICSs are going to work, they need a different quality of leadership. And we believe that's absolutely the case. So you're right to identify the danger. And my answer is, Charlotte, we need to get you in front of our ICS chairs, chief executives, NEDs, etc., and for you to challenge them to take a real step, you know, a step change. And the only other thing I'd say is, I really do, I don't bring enormous, I've been in this job for a year. I have imposter syndrome. There are lots of initials in health I still don't recognize. And, you know, but I bring to it a really deep and long-standing commitment to public engagement. So, you know, you do have an ally on the inside.
Thank you, Matthew. And
public, patient and carer engagement, I should say.
Yeah. And I would just add to that, it's great that you want me in front of your ICS leaders. I would say, let's get Sam in front of your ICS leaders too.
Oh, yes.
Yes, Robin, you wanted to come in.
Yeah, no, thanks, both. No, a really important topic. And one thing I would say that what we often find when we bring a new body in, such as an ICS, we try and kind of clear the decks and think, right, we're going to start again and do it differently. And yes, there is a need to do things differently and to add greater engagement, but also let's not lose what we've got. You know, we have got in many local areas a very good connection between particularly the local authorities, I would say, and the community and voluntary sector. And we've had health and wellbeing boards, which have been in operation for 10 years. Some work better, some don't work as well as they could, but there's still a good set of connections there. And we just need to make sure we don't lose what we've already got because we think we have to do it completely differently. And I would say as well, I think there's a little bit of a danger, and I've noticed this morning as well, that we talk about these being NHS bodies, health bodies. These are not NHS bodies, health bodies. These are integrated care system bodies in which local authorities, along with the voluntary sector, are equal partners. And I just think there's a danger. One of the things that really bothers me about integrated care systems is the guidance for integrated care boards is incredibly detailed and refined and specific. That's what the NHS generally likes. It likes directions from the top that tell it what it's got to do and when it's going to do it by. Integrated care partnerships is much more loose. Now, one way that's good because it gives the opportunity for creativity locally. But the other side of that is it could mean that it's something we don't quite get round to because we're not quite clear what we need to do. So what I would say is don't forget what we've already got and don't forget local authorities because they are key partners in integrated care systems.
Yeah, I have to say I've seen in some of those meetings in NHS England where Department of Health and ministerial team and NHS England, one after the other, keep saying, oh, and we mustn't forget the partnerships. They're so important, the integrated care partners, they're so important. And I'm beginning to think they're talked about a little bit like the VCSE. I think they're so important, we mustn't forget them, let's forget them. So I just sort of think, you know, the thing that the system keeps banging on about as so important is often not the thing that occupies the brightest minds for most of their day. So yeah, it's one to watch, definitely. Right, I've got a question for Rubina. I know the Stroke Association is kind of half commissioned by local authorities and half by the NHS often. So I think you're one of the people around the table who've got a lot of experience in working with local authorities. And I was just wondering, what do you think the NHS can learn from how local authorities get this stuff right?
I think I think our engagement with local authorities is through kind of delivery of these stroke services. And I think, what I hope that these integrated care systems will show is that actually for the patient, it doesn't matter whether something sits in the NHS, whether it's commissioned by the NHS, whether it's commissioned by the local authority. From the patient perspective, they're getting a service, and it doesn't really matter who's paying for it. And actually what's really working well for stroke within NHS England, and I would like to give some good examples of good working as well, is that we've set up, there's been 20 what they're termed integrated stroke delivery networks that have been set up in England, and these are end-to-end pathways. So it's right from prevention through to the delivery of rehabilitation and community services, and so that involves everybody from the NHS systems through to the local authorities, through to the GPs, through to the voluntary sector, and really importantly patient representation as well. And so what we really hope is through the ICS structure is that we don't, as Robin said, lose the good practice that is already happening, because this is happening for stroke with the stroke delivery networks, but it's also happening for other disease conditions as well. I think that what I would and I think we often think of the NHS as a ubiquitous system. It's not. We talk, it's not one thing. It's quite different depending on the different localities, and that's the same for local authorities as well. And actually I think there is one of the slight apprehensions I have is that if there is a lack of clarity, what we might end up with the ICS is even deepening of health inequalities. And actually, if you're in this ICS, you get this amount of care, and if you're in that ICS, they've prioritized something else. So I think there is slightly a bit of a danger around that. So what we would like to see is just the best practice, wherever that comes from the local authority, whether that's comes from the primary care networks or what's working already within the NHS, being taken forward and delivered via these ICSs in a way that does truly allow equitable experience and outcomes for patients.
Thank you, Rubina. And I'm going to hand the last word to Sam. We had a question from Gillian from Helpforce about what the roles of volunteers might be in all of this, and maybe you want to reflect on that, or even just the role of people who use services and bring their energy to improving it all.
Yeah, thanks, Charlotte. I suppose I just think that I'm an expert in me. I'm an expert in my child's needs. So being a volunteer, I think we should be seen as an expert, as a leader that can be used by organisations that should really sit around tables to help make decisions. That helps me go back to my community and know that my community is represented, be that a woman over 40 having a baby, be that Down syndrome community or whatnot. So that kind of, it very much supports diversity to help benefit our communities. But I think mostly we need to make sure that the resources are available to bring in people like me, because if they're not there, if the resources aren't there, then we can't really get to places to have a voice and to speak at the table. So resources definitely need to be available to bring us in. But I think it's very invaluable, the work of volunteers. The work I've been doing with National Voices has taught me a lot about myself, as well as learning more about health and social care and being able to navigate that. I can make the best choices for my child, and then also trying to implement change so people can make the best choices for whatever their situation may be.
Thank you so much, Sam. A really important reminder that volunteers are a great and often cheap resource, but they're not free, and that we need to think hard about how we resource good engagement with volunteers. Right, it's time for me to wrap up. You've been very patient, all of you, staying on and listening to us think this through, setting the scene for the rest of the engagement.